over time, people used to refer people who they thought had leprosy and actually had other skin infections and diseases. And so over time, the hospital has grown capacity and equipment and the supplies that actually are very good at management of skin diseases, including leprosy. So it is very important for us to know, for the people, like I've had in one of the aims of the forum in Busoga, is to end the different disease burdens that are there. And so that is to note for our people who may be suffering these conditions in that region per se. So I will go straight into the presentation. Now I'll start by giving a brief brief presentation on leprosy, which is one of the mainstream conditions that are managed at St. Francis Hospital, Ruba, or that TB and Leprosy Training Center, and which the hospital over time, over the years, has gotten pride of. Now, this may not be for academic purposes, but just to update all of us who may have had some academic information about it, but it may not very well illustrate everything that is needed for someone to be equipped at managing leprosy. I will just try to drive home some key things that are needed as take home, for all of us to know. So, as an introduction, of course, this is an extraction of the National TB and Leprosy Program that is held at that training center, and it is done often in the year, and it is a course of about 4 to 5 weeks usually. So you can really understand the work I had when I was told to summarize really some of this in just a few minutes we have here today. So I'll try to do that, but if I'm very quick and I need to state something, you will let me know in the comment sections, or my co-host, Dr. Juliet, will be able to let me know. So the disease burden of really leprosy has gone down over time. And in 2004, actually, leprosy was eliminated as a major public health problem in Uganda, which is good. However, the country is experiencing actually loss of leprosy clinical skills and less diagnosis of leprosy, and this may cause a threat to the endemicity of the disease and the infectivity and the prevalence of the disease, because we are starting to see the peak, seeing pockets of high leprosy incidences in northern Uganda, northwestern and southeastern districts of the country. So, by definition, leprosy is really a chronic infection caused by Mycobacteria lepri, and it affects majorly the skin, peripheral nerves, and mucocutaneous membranes. The disease affects people of all races and ages and both sexes. Okay, so, but in this context, we are really talking about a case of leprosy is a person with the clinical signs who requires chemotherapy, which we shall call multiple drug treatment, or MDT, and this excludes the people with the residual signs of leprosy after complete course of treatment. Because you'll know, or as you may be aware, that leprosy causes disabilities and sometimes causes permanent damage and lesions to the body. And so many people move around with these lesions. They are not leprosy patients. In fact, at our center, we actually refer to them as RFTs, and there we mean relieved from treatment. They don't have active disease, and they need not be isolated and discriminated, actually. So this is very important to note. These are examples of the patches, okay? And the source of infection and the mode of transmission is really very simple. it is believed that this Mycobacteria leprae is actually transmitted by nasal droplets, okay, from untreated people, okay? And it is the people who are at most risk are the people who are living in the same household with a person who is having active disease that is not treated, no? I think it is also important for us to remember that as soon as you try to start treatment with a multiple drug treatment, actually, somebody is not infectious within just a week. So they don't need to be isolated and discriminated as it has been with this disease, because it is so stigmatized, and that is one of the things we should try to eliminate. And if we must take anything as a take home from this gathering, really maybe that one could be one of them. The incubation period ranges from 3 to 5 years as an average, but it can go as low as 6 months, and interestingly, go as high as 20 years. You know, you get exposed today and you get the symptoms after 20 years. Can you imagine? Yeah. Being a mycobacteria, we know one of the other diseases that are mycobacteria is TB, and we know TB and its association with HIV. Now, there are cases of people co-infected with leprosy and HIV, but actually there is no conclusive evidence suggesting the association. Maybe the only association that may be there is the immune suppression, okay? But there is not such an association like it is with the TB. So the natural history is that the disease of course, affects people. Most of the individuals who get exposed to the infectious cases of leprosy become infected, but only 5% actually end up developing the disease. And majority of the cases, actually, majority of the people who get infected, actually, their immune system is able to kill off the disease, okay? And there are 2 types of leprosy that we shall be defining later in the slides. That is bacillary leprosy and post-bacillary leprosy. And this classification really is dependent on the degree of immunological defense one is able to mount once infected by the disease, okay? So that is about the natural history. The burden, like I've said, it was eliminated as a case of a disease of public health concern in 2004, okay? However, the disease is still endemic. And the challenges we have is that the scattered high burden in sites or hotspots, in other words, low endemic settings. And the dwelling knowledge about leprosy in the community as well as in health workers is really very low. And that is the most common cause actually of the new cases we get here, is that clinicians, doctors, and health workers and people in the community actually have not much experience about this disease. The disease are the cases that we get at the center actually, and all the centers in the country that treat leprosy are cases where somebody has been treated with different skin conditions, people treating diseases they are unsure of, until finally someone suggests that they should go and visit a hospital or an institution like Buruba, and that's when they actually get diagnosed with the disease. And of course, the other burden is the increasing proportions of new grade 2 disability. That is, it was at 18% in 2010, and it is now up to 27% by 2016, which indicates an increasing delay in the detection. And again, it goes back to the knowledge gap among health workers, okay? So the diagnosis really is from history and clinical examination, and it is enough to actually to provide the diagnosis. Now, it can be backed up with a biological confirmation, but actually it is the history and the physical examination, as we are going to see, is actually enough. And the case of leprosy is defined as someone who has at least one of these three. Can you imagine? Very simple to diagnose. You just have any of these three. If it is very obvious, one of those, you can actually start treatment whatsoever. And here are the three symptoms. One is the hypopigmented patch with definite loss of sensation in that patch. You have a skin patch, it is hypopigmented, it has no sensation, maybe leprosy. Number two, thickened or enlarged peripheral nerves. I'm going to show you a picture of these common nerves, okay? And loss of sensation by the areas or the regions that are supplied by these nerves. Now, there is some bit of anatomy that you may be familiar with, okay? And then a positive skin smear, okay? And the patient should have at least one of these. And if a patient is not having one of these, should not be registered as a case of leprosy, okay? And of course, the diagnosis, for you not to miss, you must be keen to examine the whole body. And these are the nerves that are commonly affected that can be used to aid the diagnosis. The cervical nerve, the ulnar nerve, the median nerve, the radiocutaneous nerve, the perineal nerve, and the posterior tibial nerves. So if you want to remind yourself of where these nerves innervate, because you need to know, okay? You see this nerve affected or swollen, you must go examine the areas and the muscles it supplies and see whether they have any weakness. You may highly suspect the disease, okay? So the classification, I said it is 2, pausbacillary leprosy, which just means you have less of the mycobacteria in the body, and then multibacillary, meaning you have excess of the mycobacteria. And the pausbacillary, if you are using skin lesions, if someone has less than 5 or 5 and below skin patches, that is pausbacillary. And if you have more than 5, 6 skin patches, you have multibacillary leprosy. And then a patient with a positive skin smear is considered pausbacillary, is considered multibacillary regardless of the number of the patches. So if I have one patch and a positive skin smear, I have multibacillary leprosy. This classification is in contrast to the old one, the one that I was taught in medical school had things to do with borderline, diplomatous leprosy, all those things. But actually, evidence shows that these are not necessary, since it is not important. The only importance is determining the duration of treatment and the course of treatment, which is only defined by pausbacillary and multibacillary leprosy, okay? And here's an example of a positive skin smear, okay? If I had time, I would go into how the skin smear is made. It is interesting to note. If you want to learn, you may visit the center. Maybe one day you will learn, okay? And the treatment, the aim is to really cure. This disease is really curable, and to prevent occurrence of disabilities. It is a very debilitating disease, and it can cause a lot of disabilities. So the goal is to really prevent disability and prevent relapse and the development of drug resistance. So multi-drug therapy is the cause, is the mainstream of treatment, okay? So, and the goals, like I've said, is really to cure, and the treatment is here. You simply just, the take home here is you simply just need to decide whether you pay first, if the patient has leprosy. Number 1, using those 3 cardinal signs. Number 2, decide whether the leprosy is multibacillary or it is pausbacillary. Number 2. Number 3 is to choose the course of treatment depending on either pausbacillary or multibacillary. Multibacillary, the course of treatment is 12 months. Pausbacillary, the course of treatment is 6 months. As simple as that. These are really take home. And the multi-drug treatment, the key drugs are rifampicin, clofazimine, and dapsone. Now, the concentration and the combination matters for multibacillary and pulse bacillary. But actually, the course of treatment, also the doses of these drugs actually may differ a little for children. And these are just take home. I don't intend to really teach you exactly everything that is done. And then the other key thing that we may have to take note of is the reactions, okay? The types of reactions, there are two majorly. Type 1 reaction and the erythema nodosum leprosum, or type 2 reaction, okay? And these reactions have of significance because the treatment also slightly differs, and the signs are here listed. Really, we may not go into them. Again, what I intend to have you take home is that somebody can have a reaction of leprosy reaction, regardless of the status of infection, whether they are still having active disease or the disease has long gone, okay? And at the TB and Leprosy Center at Luba, the main cause of admission for these patients is actually these reactions, okay? And these reactions still even occur or still need to burden these people who have suffered from leprosy even when they have completed the course of treatment. So it is very important for us to note, okay? The other thing for you to know, to learn, is that actually leprosy can relapse, you know, and you define a relapse if somebody received a full course of recommended WHO multiple drug treatment, and they have signs of new lesions, okay? And sometimes it can even occur even later than 10 years. It is considered as a relapse, okay? The other thing that we need to note is about the disability, and this is the major disturbing thing, because if you come at the Wanda Blenska institution of leprosy here at Luba Hospital, actually, you'll see people who are greatly disabled. Some don't have limbs, others don't have fingers, digits, and they can barely do anything, you know? And they still have to be dependents, and have to be taken care of, even when the leprosy has long gone and treated and even cured, okay? And that is the major thing to prevent is actually the disability, no? And like I said, in the disease burden is actually what is worrying is that the case detection rate is actually low to an extent that most of the people who are diagnosed actually are already having grade 2 disability, which is an irreversible form of disability, okay? So the disability grading is from 0 to 1 and then to 2, and we majorly examine the eyes, the hands, and the feet, okay? And we grade. There is a chart that is used for grading, and the patient, each time they come around for review, you must grade them, you know, every time they come for visits. At the initial time of diagnosis and the subsequent follow-up visits and the contacts, you must grade these people, okay? So that is important for us to note. And then the home-based care for these patients, the information that they are supposed to get is actually information that helps them prevent these disabilities and damages. Remember, leprosy affects nerves, and if it affects the nerves of the eyes, you know, the eyes can get dry and they can actually get blind, you know, and they have paralyzed eyelids that they cannot close, so they get drying of the eyes, okay? So then the problems of the hands and the feet, you must teach them how to care for them. Important to note that at the hospital, we actually have a lot of these skin care products that actually help these people take good care of themselves. Okay, so and of course there are two indicators for monitoring, major indicators for monitoring of leprosy control. One of them is the case detection rate, and this one is calculated from the number of total OPDs and the number of cases of leprosy that have been detected. Okay, now this one is very low, of course, because the disease burden globally and nationally is low, but it is very important to note. Now the other one determines the quality of service, of leprosy service, and that is the proportion of new cases with grade 2 disability. Now, this one is still very poor because of the knowledge gap among the health workers. They don't know actually how to diagnose leprosy, so they miss. And by the time somebody is diagnosed, Madam co-host help me mute those people so that we don't get background noise. Okay, so the proportion of new cases with grade 2 disability determines how good you are at diagnosing leprosy at your center, and this should be aimed at being as low as possible. Okay, because each time we diagnose somebody with grade 2 disability, then we know that much as this person may actually cure from leprosy, they may never overcome the disability that has been caused by the disease. Okay, and so they will become dependent, and then they become a burden to the community and to the family, which we don't want. That's why such forums and such information should be very important for all of us here, whether one day we shall treat a case of leprosy or not. Very important, because once you detect and you're informed and you have a high index of suspicion, then you can refer to proper appropriate centers where actually the proper care can be given. You don't have to cram and know. All you need to know is to have the index of suspicion, and for you to know that leprosy actually causes disability, and much as the disease may be curable, these disabilities, once it crosses to grade 2, it may be irreversible. Okay, so in conclusion, leprosy really is a curable disease, and the disease burden, the disease is still on. In fact, like at Loudrel Hospital, the hospital gets about 2 to 3 cases at least every quarter, and these come actually countrywide from different parts of the country. So we need to know that it is very important for us to treat the disease, but also to detect it very early, and also to know that the disease actually has reactions, and these reactions can occur whether the person is actively affected or has actually cured. Okay, sorry about that. Next, we shall go into now drug-resistant TB. And take also so now we want to go to look at some facts about TB, causes and forms, and then the burden of drug-resistant TB as requested by the forum. So, of course, TB is nationwide structured with what we call the National TB and Leprosy Program. And there is a central unit, a regional unit, and a district unit. And each of them has a role to play up to the community. That is how structured it is. And unlike leprosy, TB is fairly manageable at almost every institution, and multiple drug-resistant treatment centers. And this one, at least people are more familiar with it. But also the other thing for us to know with the TB and leprosy that actually is that TB is more common than leprosy today, okay? And the people can actually detect this, but despite the information that people have and all the knowledge and the capacity that is built nationwide, actually, TB is still killing people, both those living with HIV and those not living with HIV, and is still a disease that is highly a burden in Uganda, unfortunately, okay? Of course, there is also a laboratory structure. I may not go through all of it, but the part of the history, natural history of the disease, we may know that once exposed, about only 10% of the people get infected. And 90% of the people, when you are exposed to the bacillus, the TB bacillus, you actually don't get infected. And there are some risk factors that actually come in to determine the infectivity, why the 10% get infected. And then on the 10% who actually get infected, 90% people of the population gets actually latent disease, and only 10% get the active disease. And again, we may know or we may remember that actually there are some risk factors that come to this. And then when those who get infected with latent disease, they continue with latence, or others, once they get now other immune suppressing risk factors, they again get they get the active disease. That is important to know. And TB screening is should be intensified at all contact entrance points at any health facility. And there's this intensified TB case finding guide, which I'm sure if you have been at any health facility, you may, that is public, you may have seen this already. I may not go through it. This is for us to know and remember. And the TB diagnosis, there is a clinical, but for the laboratory diagnosis, we may remember that there is ZN or ZN staining, which detects the acid-fast bacilli. There is a gene expert. There is a fluorescence microscopy. There is the genotype and the phenotypic testing. That is blood culture and other modalities to determine resistance, which we call DST, drug sensitivity testing. That is the laboratory testing. And then, of course, we may not forget the relationship between TB and HIV. That HIV is the strongest risk factor for TB. At least it increases the TB, the risk of TB by 20 to 37%. Okay, and TB is the leading cause of HIV-related hospitalization, and the mortality is up to 27%. Okay, so 30% of the deaths among HIV positive are children with the TB. Okay, and in Uganda, it is estimated that 41% of patients of TB are co-infected with HIV. So once you get signs of TB, you should be tested for HIV. Or once you get tested positive for HIV, you should be screened for TB. The vice versa. We should always remember that. Okay. So, and of course, the other relationship in TB and leprosy is that because we may know or we may remember that it is very hard to detect actually TB in people with the HIV because of the atypical presentation. So quite often, some of these conditions actually are neglected and people think it is TB and they keep treating patients for TB, yet actually patients suffer from severe pneumonia, PJP or PCP as it was called, or pulmonary sarcoma, TB iris, or pulmonary hypertension, which are all actually diseases of the lungs that are actually very possible and can occur in people living with HIV. So you should always remember that also these diseases occur so that not every patient with HIV and is coughing is diagnosed with the TB. Okay, so again, TB iris is a paradoxical inflammatory reaction against the TB antigen, whether alive or dead, and this is simply because of the restored body immunity. This is just a reminder Now, moving on into multiple drug-resistant TB, actually, as an introduction, we know that susceptible TB favorable treatment outcomes have stagnated below 80%, meaning that the susceptible TB, the TB that is sensitive to those classical 4 drugs of TB, that is isoniazid, rifampicin, pyrazinamide, and ethambutol, it is only 80% that actually get positive treatment outcomes. Okay, and so this has led to over time an increase in multiple drug resistance. Now, each year, about 1,900 multiple drug resistant cases are estimated by WHO, but unfortunately, only about 484 cases actually are detected and enrolled on treatment. Very dangerous. Now, in Uganda, of course, we suffer a low MDR-TB case detection and notification rate simply because of underutilization of gene expert services, whether it is because of availability or underutilization, okay, and also inadequate screening systems of contacts, okay, low community awareness and the demand for TB services, okay. So all these challenges attribute to the rise in multiple drug-resistant TB. So the basic facts about drug-resistant TB, okay. Now, by definition, drug-resistant TB is said to occur when TB organisms continue to grow in the presence of one or more of the anti-TBs, okay. It is confirmed by conventional laboratory tests. That is the one based on the phenotype, or that is simply growth in a culture media, but also further molecular methods that can identify the mutation associated with the resistance. That is genotypic testing. So there is phenotypic testing and genotypic testing, okay? So now the transmission signs and symptoms are similar to susceptible TB. That's why it is very dangerous for treating someone for TB without first determining whether it is actually drug resistant or not drug resistant, because the symptoms will eventually be the same, okay? So I've already talked about the causes. Some of them are poor adherence. Others is the poor patient health education, lack of transport, side effects of these drugs, social barriers, okay, failure to start TB or identify pre-existing resistance, the initiation of an inadequate regimen, you know, some people are given wrong regimens, and many others, poor control, poor storage conditions of the drugs at the facility, okay, and so on. So the forms are really, this is a revision for those who have done some TB and leprosy courses as part of academic training or a refresher course and so on. So I'm trying to really go through so that we get a refreshment of some of these terms. Monoresistance simply means resistance to one of the first-line anti-TB therapy only, okay? And then polyresistance means the resistant to more than one of the first-line anti-TB therapy other than isoniazid and rifampicin. Now, you may remember isoniazid and rifampicin, which is the RH, are the mainstream treatment drugs for TB. So they are the ones actually that are of major focus when we are talking about multiple drug-resistant TB, okay? So, and then rifampicin resistance simply means detection of resistance to rifampicin using genotypic or phenotypic method, with or without resistance to any other drugs, okay? So this may also be any form of monoresistance, polyresistance, or multi-drug resistance, or XDR. And XDR simply means resistance to fluoroquinolones, okay? These are drugs that are used in the second-line treatment of TB. That is amikacin, capromycin, and the kanamycin, in addition to rifampicin and isoniazid. Okay, yeah, so these are some of the terms. And then the burden of drug-resistant TB globally is there. It is a continuing threat. In 2006, there was over 600,000 new cases of resistance of rifampicin. Okay, so, and now treatment of TB and multiple drug TB is actually free, but actually it is estimated that the cost per patient is 3.6 million, the short course, and 7.2 up to 18 million in the conventional regimen. Okay, so that is how expensive it is to treat multiple drug-resistant TB. Now in Uganda, the prevalence is at 1.4%, and among new, and 12.6 among patients who receive retreatment. Okay, and okay, about 19,000 cases are detected annually. This I've already said that only 489 actually get treatment. Okay, so the mortality is up to 18%, and it is high even in those people who have lost follow-up. Okay, and there are lots of side effects and there are lots of drugs that are expensive, injections and so on. Okay, and it is really very debilitating, that are very disturbing and very challenging to treat multiple drug-resistant TB. It is challenging to diagnose it. It is challenging to monitor it, challenging not only in expenses, but also in knowledge and also in capacity. So it is really something to worry about. Now, the principles of management of multiple drug-resistant TB, again, these I've tried to compress them to principles because at the end of the day, multiple drug-resistant TB is treated at MDR centers. And actually, even at our Busoga TB and Leprosy Center, it is actually not a treatment center for MDR-TB. Once we detect or we suspect MDR, I think the referral point is either Jinja or Iganga main. Yeah, that is also something to note. Okay, so the principles of treatment. Okay, early TB detection and prompt initiation of treatment to ensure success outcome. Number 2, not using drug a patient has been using as per history. Patient has been on some treatment and they developed resistance, avoid using the same drugs they have been on. Okay, use at least 4 drugs with either certain or at most certain effectiveness. Okay, so, and then 1 day dosing is usually preferred, but event of patients intolerance, split doses during the day. You know, some of these drugs should be preferred to be a single day, like you have 4 drugs, and should be the preferred way is to give all of them maybe once a day, like you give either in the morning or in the evening, but because some of them cause severe side effects and are intolerable, you are forced to really, maybe if somebody receives 4 drugs, you give 2 in the morning and you give 2 in the evening or later in the day, just to minimize the intolerable side effects of these drugs. So it is very important to note. Okay, so initiate MDR treatment under close supervision, patient education, monitoring, and treatment of drug toxicity. Okay, multiple drug-resistant TB is really treated with very serious and very toxic drugs and agents, and so as serious as the treatment should be, that is how serious the monitoring of drug toxicity should be. Okay, and the treatment of side effects. Okay, and in an injectable drug, for example, an aminoglycoside or capromycin is used for a minimum of 6 months and at least 4 months after culture conversion. Culture conversion means the culture becomes negative. So the mainstream of treatment are these aminoglycosides, amikacin, for example. Okay, so they are what we call short regimen intense phase for at least 4 months, can be given and can be extended to maximum of 6 months until smear negative. The continuation phase for a fixed duration of 5 months. Okay, so these are just principles. I'm trying to go through all of them. Okay, just to, because it is really for us to know the principles. Okay, so this is also taken as the direct observed therapy throughout the treatment. So most of the patients are actually admitted or are treated as outpatients, and they come daily for treatment at the nearest treatment center. Okay, so drug sensitivity testing for drugs is used to guide therapy. Now here, drug sensitivity testing is the key to guide to choose the choice of treatment. Now, the basic steps in starting a patient on treatment is that confirm, first of all, that they have drug-resistant TB and classify it. Okay, which resistance do they have? Obtain a baseline specimen for smear, culture, and drug sensitivity tests and initial monitoring tests. Okay, those are things to do with the LFTs, RFTs, because like I've said, we shall see that actually these drugs cause a lot of side effects. So we should be in a know that we should have baseline testing of most of the renal function, liver function, and other things, so that any change, we are able to detect it as early as possible. And then patient education is very important. Involve the family, we should inform them about the ventilation they need and the minimization of cross infection or transmission of drug-resistant TB. Okay, so select an inadequate and initiate drug. There is what we call the standardized treatment and the individualized treatment. Now, the standard treatment goes for an ideal patient, but sometimes or most of the time, this actually treatment has to be individualized because of the side effects, the type of resistance, the results of the drug sensitivity testing, and so on. They end up causing what you call individualized treatment other than the standard. That's why it is very hard if you don't practice at a multiple drug resistant TB treatment unit for you to actually master, because actually the real practice is that there isn't really much a standard treatment, but there is an individualized treatment. So you really have to be practicing daily to master this. That's why I didn't even put a lot of the drug regimens that are put. But to mention, these are some of the drugs. Fluoroquinolones that we have, levofloxacin, moxifloxacin, and the gutfloxacin. Now, maybe the one thing I may have to mention is that commonly clinicians and doctors like to treat people with fluoroquinolones, you know, levofloxacin, ciprofloxacin, people who have cough and pneumonias, you know, and actually this hinders or reduces the detection of TB, because each time somebody has TB and we treat them as a normal cough of the other pneumonias, and we give, and among the antibiotics we give levofloxacin, we are to some degree treating the TB and causing it to be difficult to detect, but also on the other hand, making it resistant, because usually when we are treating normal coughs and pneumonias, we give the course of antibiotics for a short time. So this actually ends up causing a lot of resistance. So it is a take home for us to know. Now, these drugs have their abbreviations on the other side. And then the second line injectables, these are the aminoglycosides. The common one is amikacin and the kanamycin, and then capreomycin. Okay, streptomycin is being phased. Maybe we can go and find out more information about it, but actually it used to be very friendly as a second line treatment, but it is being phased for some reasons I may not go through because of time and because of the nature of the intention of the training that we have here today. Okay, so the other second line treatment, there is a combination of these agents that you are seeing here. Clofazimine is appearing here. Clofazimine, if you remember, is a drug that is used in the treatment of leprosy and in the treatment of actual leprosy reactions. Okay, and then these other several drugs. Okay, there is a stepwise approach in designing the MDR individualized regimen. I've said again as a take home that we may not memorize, all of us, is that the treatment for MDR actually most of the time is individualized. Okay, and there are groups, a hierarchical order from A to D. Okay, and at least use 4 drugs, 4 effective drugs. Eliminate the drugs that are unsafe for the patient and don't use the drug for which they are cross-resistance. There is cross-resistance. For example, cross-resistance means that, now which common example can I use? Now, in penicillins, maybe we can talk about penicillins, that there are some cross resistances that once a bacteria develops a resistance to a penicillin, there are chances that it will develop a resistance to a beta-lactam. Okay, so meaning if a patient, for example, is resistant to amoxicillin, they may actually resist also ceftriaxone or any other beta-lactam. Okay, and that is cross-resistance. So don't give a drug when you know there is a potential cross-resistance. So these are the principles that you use to consider to choose this stepwise approach to individualized MDR treatment. Okay, so the group 1 drugs are here. Step 1 involves group 1 drugs, at least 1 in group 1, 1 in group B, and 2 drugs in group C. Okay, and so on and so forth. Okay, so the challenges that come with multiple drug resistant TB treatment is really the pill burden. Number 1, the many side effects, the longer duration of treatment. Can we imagine injections for a year and so forth? Sometimes go beyond even 2 years. Okay, co-infection with HIV is really a threat to these people, and the culture and religious beliefs. Okay, and other living circumstances like community isolation and stigma and so on, and challenges with going to the hospital, needing a good diet. Okay, all those factors actually contribute to the challenges that come with adherence of treatment for multiple drug resistant TB. Okay, patient in denial, not accepting treatment. Can you imagine being told that you're going to be treated for a disease for 12 months or for 2 years? And these are common in people who have actually attempted the treatment for TB. Maybe they treated for 3 months, they defaulted, they repeated for another 4-5 months. And then after someone diagnoses them with multiple drug resistant TB and tells them they must do what? They must they must receive a very long course of this treatment, okay? So really these things are burden, okay? So other social factors, okay? And then there is what we call adherence incentives and enablers, things that actually help some of these clients to become more adherent to the treatment. Money for transport, food, support to patients to attend daily direct observed therapy at the nearby facility, support to patients to attend monthly MDR-TB clinical reviews, okay, and contributing to the improvement of nutritional status of these patients, because the nutritional status is also very important, okay? So infection control measures are also important to note. I'm about to finish, maybe. And these include attending to MDR patients first, okay, so that they don't overstay in the crowds. Attending in a well-ventilated place, our TB clinics and our all clinics, even if they're not TB clinics, because you never know who will have TB, should be well-ventilated. And I think these days, because we have this practice of putting on masks and so on, maybe it is helping. Ensure 100% dot that all the treatment, it is ensured that it is direct observed therapy, okay? Wearing of N95 respirators, maybe this one is now more common because of also COVID, okay? And then there are also some control measures for community, for home and community care, okay, that are important. These we may know, separating the rooms for someone living with MDR-TB, spending hours outdoor during the day, like if the patient is stable, should spend most of their time outdoor, really, where there is good ventilation and aeration. And besides, they have a respiratory disease, so they need more oxygen and more fresh air, which makes sense. Opening windows at home for more fresh air in the house. These are really common sense ideas that we may all pass on to different peoples when we get the chance to share this information, okay? So MDR treatment with people living with HIV, of course, there is a challenge and there is a threat with a high mortality, and the success rate is really low with people co-infected with HIV. And the other important thing for us to know is that we should delay the start of ART when we have initiated MDR-TB because of something that I mentioned earlier, which is the TB iris. Okay. So these and among others are some of the measures or some of the considerations we need to consider for MDR-TB treatment with HIV. So in conclusion, really early detection and prompt treatment is important. Use of an initial 4 drugs where we have certain or uncertain effective, or almost certain effectiveness, sorry, and once a day dosing is preferred, although, like I said, some patients, because of intolerability of these drugs, actually, you end up dividing the 4 drugs and giving half of them during certain part of the day and half of them given at another part of the day, okay? So close monitoring is important, and prompt treatment of drug toxicity and monitoring drug adverse side effects is very important, okay? So with those few words, ladies and gentlemen, I want to thank you for having invited me or allowed me to share at the Busoga Health Forum. And I want to invite back now my co-host, Dr. Juliet,